going to be two separate. It'll be two separate YouTubes because I don't know how to merge two separate videos. I just accidentally ended the video rather than pausing it. Okay, so the exam is just like, and so we only have to learn this once, which is kind of nice. It is, it's really just like testicles. Yay, we only have to learn it once. And it really is. The exam, we start in the middle, looking at both lobes or both testicles, the same difference. There's no isthmus, I hope, between the right and left testicle, but there is an isthmus here. And so we start our exam looking at the right and left. My first images are always dead center and about in the middle of the gland, including an isthmus, because there's not, sometimes you could be on the gland and not on the isthmus. And I'll take a measurement, AP measurement. That's the only measurement that needs to be taken on the isthmus. It's just one single AP measurement. And then I'll also just do a color Doppler, just to see, because sometimes you'll do a color Doppler while the whole gland just lights up like a Christmas tree, and then you know, okay, something's going on, some kind of thyroiditis is going on. Or perhaps one half of the thyroid lights up more than the other. Same thing with testicles, we do the same thing. So after this initial imaging, I then pretty much slide off to the right side personally, and it really doesn't matter, but I always like to go top to bottom. So I go superior to the gland, all the way superior to the gland, and I come down and I'll take several pictures along the way, maybe 4 or 5 images along the way, and then I'll stop at this point again and measure across. Then I keep going down until there's no more gland, and then I go sagittal. And once again, on sagittal, you really want to go through the entire gland, including beyond the gland. So I do lateral to medial. That's just the way I do it. In fact, I just write, well, I do lat dash med. I start on the CCA just to prove well, it's also kind of nice just to show the CCA is healthy or unhealthy, because that's an incidental finding if it's unhealthy. So starting out here in the CCA also gives the doctor a reference point. So they're like, okay, CCA, now the tech is going medial from there. And so then I start, several pictures, and then, I stop here on about where the middle or the longest point is. And of course I'll measure the length, and then the height I'll measure as well. I keep going, I scan, and you could split screen sometimes, although the length of the thyroid doesn't really help. I love using split screen. You keep coming in until you find just a little bit of thyroid tissue on top of these hypoechoic little bumps in the road here. And so this is isthmus, and that's the thyroid. Let's say thyroid cartilage, just cartilage, tracheal cartilage. I'll just do cartilage, yes. So those are those cartilaginous rings, but when we're seeing them in, sagittal on the neck, we just see them as little hypoechoic oval things on top of an echogenic trachea. And then we look at the neck. So I'm probably going to I probably would finish the thyroid exam entirely. So I go to the left side, repeat everything. And then the neck. The thyroid has quite a bit, or the neck, I should say, has quite a bit of lymph nodes in it. So we are looking for those lymph nodes. And we oftentimes find, I have found plenty of reactive lymph nodes on students just because they're dealing with a cold or something. And that's one place where we start to see reactions, so a little bit of lymphadenitis. But of course, doctors aren't concerned about lymphadenitis so much from a cold. They're concerned more about cancer. So thyroid cancer can show up in the lymph nodes rather quickly. One thing, I'm not sure your book gets into this, status post thyroidectomy. In other words, the thyroid's been removed because of cancer. Well, we do an exam, and doctors will invariably, they'll order a thyroid exam, and then depending on your facility, you either, if it's so obvious, sometimes we do have permission to simply change the order. Most of the time, when you have a change in order, you should call the doctor, by the way. But there are certain instances that are just so common and so understood that the insurance companies will be fine with it, but definitely figure out what you do at your facility. But they'll order a thyroid, and the person doesn't have a thyroid. What they really want to do is a soft tissue neck. And so in both of these situations, whether they have a thyroid or not, we want to look at the neck. And that's really the anterior neck from, I'm not going to write it down, I don't have room, but all the way from basically the mandible, maybe almost up to the ear. We're scanned all the way down to the clavicle. And obviously we're looking for any kind of reactive nodes. And if they've had a thyroidectomy because of cancer, and they come back for a thyroid exam or a soft tissue neck exam, that is definitely what you're looking for, is any kind of cancerous or reactive nodes for cancer. So without being in lab, that's pretty much all I could tell you about the actual exam. And then while you guys are on break, I realized I didn't have a space for my cysts, so I had to kind of squeeze it in here. Hopefully it wasn't too tight. There wasn't much to say about them anyway. And I do have some images though. So cysts of the thyroid, very common. I've got a complex cyst on my right. It hasn't changed shape or size in years, so I don't worry about it. It's not going anywhere. It's not doing anything. So cysts are very common. You could have a simple cyst. Whether it's simple or not, it's probably a colloid cyst. It's very common. Colloid is basically viscous fluid. So you could have colloid cysts in different parts of the body, but viscous meaning a thick fluid. Colloid cysts in the thyroid oftentimes have this echogenic foci either on the edge or sometimes right dead center. It's a little bit weird. And it can have a comet tail artifact. So you have a little foci and a little comet tail artifact coming off of it as well. Hemorrhagic cysts, just like anywhere else in the body, a cyst that has bled into itself is going to be heterogeneous. It's also going to be more concerning. So Simple cysts are not terribly concerning. Hemorrhagic cysts are more concerning. And then there's a question of cancer. And here's the thing about thyroids, guys. We do a real good job of imaging them and showing doctors what's in there. We have no idea what's in there, if that makes any sense. We have to do FNA, fine needle aspirations, in order to find out. And we do assist the doctors very often in FNA. And fine needle aspiration, by the way, my first class, big guy too, almost passed out during his first fine needle aspiration, because what they do is they take a little, it's a regular needle, just like you're getting an injection, and they stick it in through the neck, and you have some lidocaine, so it shouldn't hurt. They find the tumor, and then they just jam. And I guess it really bothered one of my students, and he almost passed out from it. So just as a warning, that's what they do. And it might seem rather harsh, but what they're doing is they're literally forcing, every time they jam the needle in, they're forcing a few cells into the needle. And then they take the needle out, push the contents onto a specimen plate, and then the doctors take a look at that. I did have a doctor come in, and he did a core biopsy. And so, you know, if this is that's a fine needle aspiration, core biopsy is like that. And the doctors where I worked for a number of years, they would do maybe 3 or 4 passes with the fine needle aspiration, jamming it back and forth multiple times, but basically in the same area, just boom. Then this core biopsy, this guy, this radiologist, young radiologist, he did like 10 core biopsies of a thyroid. I'm like, you don't know what to say sometimes. He's a radiologist, he's your boss, you know? And I finally said, so, doctor, maybe we can send this over to pathology and they can take a look at it. He kind of looks at me, you know, like, who are you to tell me how to do this? And I was getting stressed out because this guy had removed half the thyroid just through the core biopsy gun. And they called back immediately, said, please no more, because, yeah. So they don't usually do core biopsies. They might. The thing about core biopsies is, I think I told you guys this story too, is I saw one go right through the carotid artery. And that's one of the things you're doing, is helping the doctor not put a needle through the carotid. I mean, it's bad enough to put a fine needle into the carotid artery. To put a core biopsy in is worse by a lot. And I've seen that happen. So that's part of our job, is to step up and say something when you see the doctor doing something that might not be the best idea. Okay, I got some images of cysts here. Oh gosh, you know what? I don't even have the, we'll just describe what we see. Because, oh, you know what I do have? No, I don't. All right, we'll get back to it. Okay. Let's see. Right lobe. The entire right lobe is taken up by this cyst here. Can I draw this? Yes. There is some material in it, so it's no longer a simple cyst. This probably was a simple cyst, but a little bit of material, perhaps hemorrhagic. Just a little bit of blood has got into it, but that's a pretty simple looking cyst. Once again though, a cyst is, a lot of doctors will say it is cancer until proven otherwise. However, this one is not cancer. We see this all the time. This is your colloid cyst with a little echogenic foci, and that's basically hardened colloid. So a colloid cyst itself is a thick tissue. If it hardens and dries out at some point, it will create that little structure, usually in the middle. So when you see that, that is a very common thing. Not saying it's not cancer, but probably not. And let's see. Oh, now this one is a little more concerning. We do have a structure over here with a number of echogenic foci in there. Now, could that just be colloid cyst with a hardened colloid around it? Yeah, it very well could be. It probably is. But just like in every other organ, if you find multiple calcifications, these might be calcifications. When you find these multiple point calcifications, that is concerning for cancer. So this guy's a little more concerning to look at. Once again, over here, there's our esophagus, strap muscles up top. That's just not a good picture here, but it certainly looks like a hemorrhagic cyst on the left side. Once again, that could be cancer. You know what, this, gotta put on my eyes here. D. This transverse image to the right. Thyroid lobe showed complex thyroid mass, which on biopsy was identified as a degenerating cyst. Yeah, but that's not the right. That's a mistake. There, the person's holding the transducer backwards. Let's see what else. Transducer thyroid, all circumscribed, concerned with good through transducer, debris along with colloid elements within the cyst. Okay. Transducer shows a small central colloid cyst, kind of tail artifact, small cyst identified. Okay. So they're saying this is the right. I don't see it because I'm thinking that's trachea over here. So I don't know how that would be right. It looks like left to me. Simple mistake. They simply called this one up here complex. Well, yes, it's complex. And so is this. It's also complex, perhaps hemorrhagic. Oh wait, on this. No, okay, sorry. So this one actually is carcinoma. Now, when we look at that versus, well, let's say that. I mean, this one's certainly more simple up here, but it has some elements in there. This one looks bigger and similar to this one, but this is just simply a degenerating cyst, a hemorrhagic cyst, but this one's actually cancer. So it gives you an idea. We're not very good. We're very good at finding things. We just don't know what we're finding when it comes to thyroids. Some nice findings here. There is a structure here, which does not have an arrow to it. Not much of a structure though. A little colloid cyst there. Probably another colloid cyst there. But of course, we're looking at a perhaps an adenoma with a calcified ring around the outside of it. Yeah. So according to the book, according to the doctors who looked at this, this was just an adenoma. which we'll talk about soon. There's a little bit of calcified ring here. I believe this one was a calcified adenoma as well, with some serious shadowing behind it. And, oh, I see. And they did some imaging there. Adenomas oftentimes will have a hypoechoic ring. So you have this hypoechoic ring around the outside here. And cancer could have that too. So once again, we don't know for sure that that is normal. In fact, the doctors I know would fine needle aspirate everything they saw that was big enough to fine needle aspirate. Up in, I think half a centimeter was the smallest as they would look at. Let's see. 41-year-old. I hope I know if you. Benign hypoplastic nodule, nodular goiter. There's too much for. Okay. Yep, adenomas as well over here. Increased color flow. Unfortunately, once again, even hyperemia, increased color to a nodule, doesn't tell us much. Does not tell us whether or not it's truly cancer. Okay. And once again, non-cancerous nodules there as well. Wow. Hemorrhagic. Okay, let's talk a little bit about nodules then. And is that out of place? So one of the things that we'll do is we will follow up on nuclear med. So nuclear medicine is really good for the thyroid. A lot of the hormones are well seen on nuclear med because hormones take up certain substances. In the case of the thyroid, it's iodine. So the TC99M scintigraphy is you put radioactive iodine, so radioiodine, into the body, and they wait. And what they do, this scintigraph is this camera that looks at the body, looks pretty much at the whole body, and as radioactive material comes flying out of your body, hits the camera, very expensive cameras, by the way, like $1 million cameras, as it's hitting that camera, it's showing up, obviously, on the, it gives an outline of the body in radioactive decay, which is a little scary. But there's two kind of nodules that can be seen here, and that is a hot and cold. Hot nodules, those are hyper functioning. I was going to say hyperactive. Hyper functioning nodules can be seen. And here's the good news. It seems like a hot nodule, hyper-functioning, that's a problem, right? Well, it might cause physiologic problems if it's hyper-functioning, but they are almost never cancer. So if you do have one of these, if you have nodules at all, you want them hot. Cold are hypo functioning or not functioning at all, and they are sometimes so just because you have a cold nodule doesn't mean that you have cancer, but it might be. And I wasn't able to fit the image in the right spot, so let me run down to here real quick. So here's a close-up. They could do full body scintigraphy, or they could do, like in this case, they came up close to the neck, and you can almost see the outline of this person's neck here. And this person has a cold nodule. It took up just a little bit less of the iodine. This person, a nice little pyramidal lobe right there. Anyway, this person has, let's see, a cold nodule over here, cold and hot. Toxic multinodular. Toxic simply means that it's causing, the hot nodules are causing physiologic problems. There's too much thyroid hormone. Hot nodule. Autonomous nodule, suppression of the remainder of the gland. So it kind of looks like this person's entire left lobe is nodular, or is made up of one nodule perhaps. And it's so hyper-functioning that the rest of the gland is pretty much turned off. You comfy, Priscilla? And this person has thyroiditis, and they are at this point in their degree of their disease, they are hypothyroid because there's nothing showing up really. So they don't have normal thyroid function at all. Okay. So let's see, adenomas, nodule. Whenever we see something, we call it a nodule. We usually don't call it an adenoma, but adenomas are so common of some sort or other that adenoma and nodule are pretty much mean the same thing in the case of the thyroid. So they could be benign or cancer. Adenomas, true adenomas. Let's see, 10% of all benign neoplasms are adenomas, and they are 7 times female to male prevalence. So 7 times as many women have adenomas as men. And we do find that women are far more likely to have adenomas. When we use the term toxic adenoma, that is hyperfunctioning. So that one little adenoma, or it might be large adenoma for that matter, is putting out way too much T3, T4, way too much hormone, and the rest of the body is obviously suffering for it. And then there's also the term thyrotoxicosis, and that's really very similar. It's actually the effects of toxic adenoma. So thyrotoxicosis, the overall physical effects of a toxic adenoma. So as I mentioned before, adenomas, they grow very large. And of course, they're going to cause problems when they're very large. No longer are we going to be able to swallow our food all that well because we have a thyroid in the way. or a nodule in a way, I should say. What else is or on the outside, you will oftentimes find a halo. A halo is a common finding. And what that halo is, so you have a tumor here, and then this dark halo around it. And that could be compressed thyroid tissue. It could be blood vessels. And also comprises, there's also the capsule itself. So that would be like here's your actual nodule in there, and then the halo, and then thyroid tissue on the outside here. A non-toxic goiter. A goiter is a increased thyroid, and most likely caused by, in a non-toxic goiter, is probably caused by iodine insufficiency. Thyroid iodine insufficiency. So we don't see a lot of that in particular in the United States, but in third world countries where they're not getting enough iodine in their diet, the thyroid will grow larger in order to capture all the iodine that it can. Multinodular. Looks like I screwed up here, guys. Hold on. Where's my... All right, I can't find it. All right, that's okay. Let me just do something else here. Okay. Okay, we're back. What was I on? I was on yeah, so thyroid iodine insufficiency. Yeah, that's fine. Multinodular goiter. Once again, an increase in size. You can be euthyroid. Maybe. Now I need to define thyroid. Can be euthyroid. Euthyroid is normal function. Or with multinodular, and I've seen this. I've seen people with just horrible looking thyroids, and they have completely normal function. They don't need anything. They just have a big neck. Or they sometimes also can be toxic, meaning too much T3, T4, which sometimes leads to too little. So as the disease progresses, it goes from too much to too little over time. With a very large goiter, first of all, it's going to be visually very obvious on the neck, but they could have trouble swallowing, dysphagia. And so a lot of times I do have patients come in for dysphagia. Every time they eat something, they feel like the food is going past something and they're just not. And so the doctor says, well, you need a thyroid exam. And very often though, I find nothing. Sometimes I do, but a lot of times I find nothing and don't know what to say about it. You know, I don't, because in other words, I don't know why these patients feel this way. Oh, wow. Okay. So I hesitate telling you this. All right. Okay. You guys have to remind me to tell you the thyroid story when we get back and how I thought I was going to get fired. Because I don't, my wife is right over here. I can't tell the story. Besides, we're being recorded. So.
What was that? What did you say?
Shut up. Can't tell the story right now. All right, I'm actually done on my notes. Let's just look at a few pictures. 249. That's good. We did fine here. So this person's interesting. Let's get a pretty color here. Let's see, normal isthmus. That's nice. Mostly normal left, although actually not completely normal. There is something right here. But there's a lot of normal tissue here. Then we go to the right side. And that is all one big thyroid nodule. Degenerating, notice how it has in the middle of it, like here's a thyroid, there's a nodule there, and it's degenerating in the middle. That typically is a loss of, it grew so fast that the arterial and venous flow could not keep up with the growth and it died in the middle. So that oftentimes happens. There is a hypoechoic on the outside halo. That halo, like I said, just could be just tissue being squeezed off on the side. Here's our little CCA. This thyroid's becoming so large that it could actually affect brain function, really. I mean, if that CCA ever got kinked off.
Could that cause like bleeding, like while coughing?
That would be really scary because that would mean that blood has somehow crossed over into the trachea. So probably not, but if it did, that would be pretty bad. Here is another beautiful picture. Here's the trachea. And that makes this the isthmus. You guys probably know by now that's a little bit large for an isthmus. They have arrows going to multiple nodules, and here's our CCA, CCA. But really, depending on my doctor and how picky they were, I wouldn't even, what are you going to do? Measure each one of these? I used to. When I was a brand new tech, I was told you got to measure everything. Measure. Well, at some point, it gets old. When you're really busy, it gets really old really fast. So personally, I would take maybe a couple of grand measurements, and the doctor, or perhaps the largest single nodule I would measure, but then just indicate that the entire gland is one big nodule. And I grabbed this one, and just because it was funny looking. Sagittal, left thyroid gland. So overall thyroid appears to be like that, which is an odd shape. And then this is just an evil looking pumpkin guy. So, all right. So tomorrow, more thyroid. We get into more of the hyperthyroidism and talking about what that really means. Hypothyroidism, thyroiditis, carcinomas, lymphomas. We gotta always talk about lymphoma with every single thing we look at. Metastases. Oh my gosh, we have to do parathyroid glands too. Yeah, actually, I don't think we'll finish the chapter tomorrow. I kind of forgot about the parathyroid glands. Those are 4 little tiny glands that work in opposition to the thyroid when it comes to calcium. So calcium balance between the thyroid and the parathyroid glands. But yeah, we got to talk about those guys too. So yeah, we got a big day tomorrow, and then we'll probably continue this on Monday, which is fine. All right, so tomorrow I'll try to get some homework up and be ready for class. Any questions or anything?